Hello, we are the Group 5B and we will present about diabetic ketoacidosis secondary to community-acquired pneumonia. Patient information. Patient is a 52 years old Malay female who was sent to the ER with chief complaint of worsening SOB and epigastric pain. For HPI, on 12 April, she visited KK Sungai Besi. She experienced cough for 1 week, fever for 3 days, SOB on and off for 1 week, which worsened today, lethargy, vomiting for 3 days, 2 to 3 times per day, and she has a white cell count of 26.3 and blood sugar of 27.0 mmol per liter. For past medical history, patient was diagnosed with diabetes mellitus, hypertension, and dyslipidemia since 2007. She has a history of hypothyroidism with thyroid goiter. She was on OHA and insulatide, however, she was non-compliant. She did not take any medication for hypertension and dyslipidemia, and she was only on hypothyroidism meds during pregnancy. For diagnosis, patient is diagnosed with diabetic ketoacidosis secondary to community-acquired pneumonia. She experienced signs and symptoms of fever, 38.4 degrees Celsius, SOB, vomiting, dehydration, and epigastric pain. She has a pH value of 7.192, random blood sugar of 32.5 mmol per liter upon admission, blood ketones of 4.6, and bicarbonates of 11.0 mmol per liter. These readings are indicative of diabetic ketoacidosis. Next, patient is diagnosed with community-acquired pneumonia, CAP. She presented with shortness of breath, cough with yellowish sputums, fever with temperature of 38.4 degrees Celsius, heart rate of 135 beats per minute, respiratory rate of 36 to 43 count per minute, and a high white cell count of 26.3. This is indicative of infections. Chest X-ray revealed right lower lobe consolidation, confirming the diagnosis of community-acquired pneumonia.
Moving on with the lab results. Upon the admissions, the white blood count was uncontrolled, showing a signs of infection, but it keeps decreasing throughout the admissions, indicating that the infection is resolving. The neutrophils are showing a high reading, and a high percentage of neutrophil is a sign of infection. The signs of infection were also shown by low lymphocyte count and high CRP in the blood. A brief of the patient's progressions. She complains of shortness of breath, cough, fever, and neck swelling during admissions. She also has fever on 15 and 16 April. The results of the CNS test comes out on 18 April, showing that the bacteria is sensitive to ceftazine. Starting from 21st April, the patient complains of cough and fever. The patient has hypertension but currently is not taking any medication for the disease. Her elevated blood pressure was resolved after administrations of perindopril on 13 April. The blood pressure keeps on dropping, so they withhold the antihypertensive agent. Low blood pressure can be contributed by infections. The reading of the red blood count and the hemoglobin are low, indicating the presence of anemia. The lab result is showing a high reading of ALP, high reading of ALT, and total bilirubin. The abnormal liver function test values might occur due to pneumonia, and it can progress to liver injury. The patient has a low albumin reading, which might occur due to acute phase reactions or liver disease. The lab result shows that the patient has a low serum creatinine. A low level of creatinine can mean some types of liver disease or diet low in creatine. This leads to the high creatinine clearance. The patient also has a low level of sodium in the blood, indicating hyponatremia. A low reading of sodium has many causes, including kidney failure. The reading of the urea was high during admissions. which means that the kidney are not working well. The potassium level start to drop starting from 13 April. A low potassium level has many causes but usually results from vomiting. The patient also has a low phosphate level in the blood, which can cause energy levels of the patient to drop and cause fatigue and muscle weakness.
The pharmaceutical care issue of this patient is that this patient has abnormal LFT values that might progress to liver injury. This is important because liver might affect drug metabolism. Hence, we need to refer to physician for reassessment of liver impairment and closely monitor the LFT values. Other than that, this patient also had hypoalbuminemia and could affect drug that bind to albumin. Hence, we recommended to add on protein in the patient diet and closely monitor the albumin level and serum creatinine level. The dehydration status of patient is unknown because the IO chart is not complete and cannot be assessed. Hence, we need to closely monitor the IO chart and signs of dehydration on the patient. Patient might not be taking any medication for her hypertension and dyslipidemia because there is no data available inside the past medication history. Hence, we need to reassess patient condition for the need of medication and provide patient education to improve adherence. We also should monitor blood pressure level and lipid profile. This patient also non-compliant towards her anti-diabetic medication. Hence, we need to educate patient on importance of adhering to her medication and monitor closely her blood glucose level and HbA1c. Another drug-related problem is that during immediate treatment of DKA, patient receive insulin infusion of 6 units per hour, which does not follow the guidelines stated in CPG, whereas infusion should be 0.1 unit per kg per hour. Hence, based on patient's weight, patient should receive insulin infusion rate of 8 units per hour, and the blood glucose level and arterial blood gas as well as potassium level should be monitored. Other than that, this patient received simvastatin 20 mg without past medication record and without monitoring of lipid profile. This raises question of whether patient really needs such treatment or really needs such dosage. Hence, we need to obtain the lipid profile of patient and reassess the patient condition for the need of medication and appropriate dose. And the close monitoring should be done on the lipid profile. Also, there is unclear indication of lactulose because patient received dose indicated for constipation, although there is no symptom of constipation noted in the progress note. Hence, we need to really assess the need of lactulose medication, and close monitoring should be done on the IO chart of bowel movement and also the complaint of patient of difficulty of pooing. Another drug-related problem is that enoxaparin as DVT prophylaxis was inside plan in progress note, but not in medication list. Hence, administration of drug was unknown. However, on 14th April, progress notes noted that drug was withheld and platelets numbers start increasing trend in the lab result. Since DKA may induce high risk of DVT, patients should be given enoxaparin 40 mg OD until risk of DVT has diminished, or continue along the admission in the hospital, and close monitoring should be done on the platelet level. Apart from that, there is unclear indication of esomeprazole treatment. This patient received esomeprazole dose indicated for gut pain. However, there is no symptom of gut such as heartburn pain noted in progress note. Hence, there is unclear indication of why esomeprazole was given to this patient. Hence, we need to reassess the need of medication and we need to closely monitor any complaint of gut pain by patient.
This is the current medication list for our patient. Now let's move on to the management of patient. The first management for the diabetic ketoacidosis is the fluid replacement. As recommended by the CPG Malaysia and UK guideline, 0.9% normal saline should be given for the first hour and the next few hours at different infusion rate, and once the blood glucose falls below 14 micromole per liter, the fluid should be switched to 10% dextrose. In our patient, no saline is given, but the rate and the volume is not stated. 1 pint of surafendin was also given in our patient. So according to our research, there is no significant difference in the reversal of acidosis, as well as mortality or morbidity between the use of surafendin and 0.9% normal saline. So we think that the management is acceptable, although there is little evidence to support the use of surafendin is superior to normal saline. Besides, the dextrose solution administration was not stated in our patient data. For the management of potassium replacement, Malaysia and UK guidelines suggest that potassium should be supplemented if the potassium level is below 5.5 micromole per liter before insulin therapy can be started. Our patient had 5 micromole per liter of potassium level on the first day, which means that our patient requires this management. However, this management is not stated. So for the potassium supplementation is on 13th of April until the 16th of April, but our patient potassium level is very low on 18th of April, which is 2.6 micromole per liter. So we would like to suggest that potassium supplement should be continued until the patient potassium level reach the normal range. In the insulin therapy, 50 unit therapy in 50 ml normal saline was given to our patient at a rate of 6 units per hour. However, we would like to recommend to use an 8 unit per hour based on the calculation using the body weight according to the Malaysia and UK guideline. Besides, when our patient want to change from the infusion insulin to subcutaneous insulin, the previous regimen shouldn't be used, as our patient HbA1c is high, which is 9.1, and patient is non-compliant to the regimen. So we try to calculate the basal bolus regimen, and we obtain total daily dose of 62 units. And it is quite close to the total daily dose given to the patient in the wards, which is the 66 and 68 units. And we think that the management is appropriate since the overall our patient RBS was under control and our patient has been diagnosed with diabetes since 2007 and has been using insulin for quite a long years. So insulin resistance might happen in our patient. So for the phosphate replacement, our patient have a very low phosphate level, which is 0.28 micromole per liter, and our patient is anemia. So we think that the phosphate replacement in our patient is appropriate. In the magnesium supplementation, although our patient magnesium level is normal, but papers support that co-administration of magnesium may help to correct the hypokalemia more effectively. So we think that this management is acceptable. Move on to the management of CAP. Antibiotic used in our patient as empiric therapy was ceftriaxone and azithromycin, which is the alternative therapy. We would like to suggest to use augmentin and azithromycin in our patient since our patient is not penicillin allergy, and exposure to cephalosporin use may increase the risk of multi-drug resistance. On 16th of April, escalation to a broader spectrum antibiotic, which is the tazocin, and we think that it might be due to the persistent fever and high white blood cell, which may indicate that the infection is not resolved. So we think that this management is appropriate. On 18th of April, cefepime was used in the directed therapy after the blood culture and sensitivity was out. For fever, patient body temperature was high on several days, but paracetamol was only given on 13th of April. So we think that patient might be given state dose, but it is not recorded inside the medication list, or if the patient is not given paracetamol, then there might be an error in the management of fever. For the monitoring plan of DKA, we should monitor the random blood glucose level 4 times daily to prevent the recurrence of DKA and hypoglycemia. Besides, we should monitor the potassium level daily and monitor the complaint of weakness, muscle cramps, and GI symptoms. If severe hypokalemia happens, we should monitor the ECG. Besides, we should monitor the IO chart and physical status such as skin turgor and tongue to prevent dehydration, and monitor the platelet count to prevent deep vein thrombosis. For the monitoring of CAP, we should monitor the body temperature, white blood cell count, neutrophil count, and CRP value, as well as the culture and sensitivity test for the infection monitoring. Besides, we should monitor the liver enzyme, as pneumonia may cause liver injury, and we should monitor the safety of antibiotic use.
Lastly is the role of pharmacists in patients management. The first one is to check for the appropriateness of the treatment given for her diabetic ketoacidosis. Next is to reassess patient's diabetes mellitus condition and treatment. We also need to reassess patient's hypertension and dyslipidemia condition since there were no treatment recorded for these diseases. The fourth one is to monitor patient's clinical condition during her treatment in the hospital. And lastly is to educate patient regarding her adherence issue towards her medication. And these are the references that we use. And that's all from us. Thank you.